Okay, well, thanks for coming on a beautiful day. And Jen, thanks for inviting me to come back. Always a pleasure. So what we're going to talk about today is macular degeneration as it stands in 2016. And so what I'd like to do is kind of cover a few different things, but start off with trying to understand what goes on with macular degeneration, the different types of macular degeneration, okay, and then talk about the history of it and how far we've come in the last 20, 30 years actually, and then talk about where we're at right now, and then talk briefly about what the future holds. And I was fortunate enough to still did my training in the dark ages of macular degeneration, and so I have a very strong appreciation of where we've come in the last 30 years. It's really quite amazing. I used to describe myself as the Grim Reaper when patients would come in with macular degeneration. I was the last stop. I held the person's hand and watched them slowly lose their central vision. And today, the vast majority of people that I see, I expect their vision to at least stabilize, if not improve, from their initial visit with me. So it's really quite a remarkable story. Anything that's in this lecture, it's actually being recorded. And also you can go to my website, Montana Retina Consultants.com, and you really don't have to, I mean, you can write things down, but I would suggest you kind of just listen and you can get the specific information off my website or on the video that's being recorded. So just briefly to review, I always think it's better to assume we're starting with no basic knowledge than to assume you have a knowledge. And I tell people, think about the eye being like a camera, okay? Light comes in the front of the eye, is focused by the lens of the eye, okay, onto the back of the eye, into the film of the camera, which is the retina. This is the orange layer. And more specifically here, this is the lens of the eye. This orange layer is the retina. And the light rays are focused into this fine pinpoint area called the macula. So the macula is responsible for our central vision, our reading vision, our driving vision, any close detailed work that you would do, that's what the macula is responsible for. Looking at the macula in the anatomy of it, I want to kind of just outline a few things. The big thing here that I put out is the RPE. So this is the one cell layer thick barrier between the underlying choroid, which basically is responsible for the vascular supply to the retina, okay? And this is the barrier. Bruch's membrane is part of the RPE, and this complex here, okay, is what basically breaks down with macular degeneration. It's all the retinal pigment epithelium breaking down, and so we're going to show a lot of pictures about this retinal pigment epithelium breaking down and what happens with that. So this is an OCT scan. We'll get into the specifics of that in a few minutes, but I wanted to give you an idea because we're going to show you some pictures. This is normal. This thick layer right here is the RPE. Okay, these are the multiple layers of the retina, but this thick layer right there is the RPE, and you'll see that change over time. Again, what happens with the aging of the macula is the retinal tissues break down, but more specifically, it's a disease of the RPE, this retinal pigment epithelium. The RPE is responsible normally for the byproducts of metabolism for the photoreceptors of the retina. And as we get older, it starts to break down, doesn't function as well, and we get the formation of drusen and atrophy, and then eventually a breakdown of that Bruch's membrane, that barrier between the vascular supply to the retina and the photoreceptors. You can see here in this picture, this is a beginning of a thickening of Bruch's membrane. This is the RPE here, and there's a thickening of Bruch's membrane and a collection of material, and those are called drusen. And that's what we're seeing in this clinical photograph, are these little yellowish areas right here. And so this is an early stage of dry macular degeneration. There's two types of age-related macular degeneration. There's the dry type where there's tissue atrophy. The tissues just kind of deteriorate over time, and once the RPE is degenerated enough, the overlying photoreceptors are damaged and also die away because of the RPE death. And then there's the wet form, okay, which happens much more rapidly. Everybody starts off with a variant of the dry form, And then a subset of people will then progress and develop the wet form with the neovascularization. And that's what occurs when the choroid starts to send vessels through that breakdown in Bruch's membrane underneath the retina in the macula. So again, dry macular degeneration, it's the initial phase of the disease. It's the vast, vast, vast majority of patients. There's no abnormal, there's no abnormal blood vessels. And usually, again, the vast majority of people, there's just a mild to moderate visual loss over time. Again, the drusen represent the RPE disease. So if I see somebody like this in my office, this is somebody that I will do some testing on and monitor more carefully. This is again showing that OCT test, and you can see the drusen here clinically, but you can see the bumps and the irregularity of the RPE indicating these drusen. And again, just another photograph of it. This is a color photograph, but these are both OCT scans. And again, the drusen. So this shows us, or this tells me when I look at these scans, this is a person who has dry macular degeneration, has pretty significant RPE disease, and so somebody that I'm concerned about may develop wet macular degeneration in the future. Okay, doesn't mean they will, but they're definitely at higher risk. And again, that gets this photograph, and it depends on the number of drusen and the quality of the drusen, and we don't want to necessarily get into that. But suffice to say that this is a patient with high-risk drusen who I'm concerned over time, depending on their age and longevity, will develop the wet degeneration. In most people, if you don't develop the wet degeneration, you have this sort of slow progression of the RPE disease. You'll see these again, the progression of the drusen formation here, okay? And again, in these cases where there is a progression, reduced central vision, sometimes a central scotoma, which is a dark area in your central vision. Distortion's a big thing when you look at a telephone pole or a light pole and it's wavy, okay? There's decrease in contrast sensitivity and also can be a decrease in color vision. Again, mild to moderate visual loss for most people, slow progression, and unfortunately at this point, no effective treatment. We're going to talk about that later as to what's down the road with dry degeneration and what we may be able to do. But right now, it's trying to slow it down, and we'll talk about what we have for that at the present time. So there's two forms, again, to state, the vast majority of people have a variant of dry macular degeneration. The symptoms are not that bad, and most people live with it their whole lives, and it's not that big a deal. It's an annoyance. But there's a subset, and you can imagine as the population's aging, okay, and the demographics are what they are, okay, we're having an explosion of people coming in with the wet degeneration just because of the number of people and how long people are living. So the two ways that you can have severe vision loss with macular degeneration, one is with the abnormal blood vessels growing, okay, and the second one is what we call the non-neovascular, the dry form, where the drusen and the disease of the RPE and the breakdown of Bruch's membrane is so severe that they develop severe atrophy over a very, very gradual period of time, a long period of time, and they lose their central vision on that basis. And this is the worst case scenario for most people, whether it's because of atrophy, or abnormal blood vessels growing. This is kind of what you could expect to experience. You do retain your peripheral vision. The vast majority of people retain their ability to function and take care of themselves, but reading, driving are usually off the table if it's in both eyes. And for most of us who are used to being very independent, that's still pretty devastating.
You say this is the dry you're talking about?
Either one. I'm saying the worst case scenario for the dry or the wet is what is looking at that. So again, this is a geographic atrophy, and you can see here on the OCT how you have the loss of the central tissues. The RPE dies, and therefore the photoreceptors over the top of it atrophy and die, and there's just no functioning of the macular area. The peripheral retina is intact, and so they do maintain their peripheral vision. The other, again, way, and this is really what we're going to talk a lot about today, is the wet degeneration, choroidal neovascularization. Basically choroidal vessels, new vessels from the choroid that break through that Bruch's membrane underneath the retina. Just again reviewing what we looked at before, we have the deterioration of Bruch's membrane in the RPE as evidenced by the drusen. And what basically eventually happens is these new abnormal vessels start to proliferate and try to penetrate through Bruch's membrane. And that's what you're starting to see here, is you're seeing these little spots of hemorrhage, which indicates abnormal blood vessels starting to grow and leak. And this is a really nice diagram of it. So this is, again, a drusen. There's disease of Bruch's membrane. You see these abnormal vessels kind of just hanging out here, waiting or trying to find a break in Bruch's membrane and to scoot underneath it or through it and underneath the retina. And you can see there's a break that develops, and then the vessels start to grow. And this happens over weeks to months. And then eventually the vessels become mature enough, they start to leak fluid, and then they break through the RPE and they leak more fluid. And the end stage result of this, if untreated, is that you get these abnormal blood vessels that hang out here that eventually turn into a scar. And this is what's called a disciform scar, and is equally devastating like the atrophy of wiping out the macula entirely. And so, again, this is another disciform scar, development of wet AMD. So how do we diagnose macular degeneration? So two ways we diagnose it. The previous gold standard used to be fluorescein angiography, and now really ophthalmic coherence tomography, or OCT, has taken over. It's a much more non-invasive test. Fluorescein angiogram we still do, especially on our initial visit with the patients, and then usually after that, it's pretty rare for me to repeat the fluorescein. I like to get it as a baseline and look at both eyes, because sometimes you'll miss something on the OCT and you'll catch it on the fluorescein. But basically what we do with fluorescein angiography, it's an intravenous dye injected into the back of the hand, and the leakage of the dye occurs from the abnormal blood vessels that are growing underneath the macula. So the normal vessels in the retina will basically stain with the dye as the dye flows through the normal vessels, but also the abnormal blood vessels will stain. It's an in-office procedure. The only downside to it is there's a rare allergic reaction, much like somebody allergic to a bee sting. Okay, fortunately in my career I've not had anybody have that, but anaphylaxis does occur. There are people who go into anaphylactic shock, and we have epinephrine in our office to combat that if it ever occurs. But overall, it's a relatively safe procedure. So with wet degeneration, this is what you see on the angiogram, and this is in the early stage, mid-phase, mid-late phase, and then the late phase, and you can see these vessels filling with the dye and then leaking later on, and that's what we used to see when we did the fluorescein angiogram. With dry degeneration, we see really the opposite. We see this initial defect because there's what we call a window defect because the RPE is gone, and over time we see really nothing happen because there's no abnormal vessels, and that tells us it's the dry form and not the wet form. Again, in dry degeneration, the drusen will stain, and we can see all these drusen here. And then what we have now, and which is really our gold standard in 2016, is ophthalmic coherence tomography, or OCT. And again, this is a normal appearing OCT. It's non-invasive, the cost is low, and the resolution, the images are super high resolution now. It's really still amazes me that we're able to look at the macula in such a way and under such high resolution. What happens with OCT is we basically take a series of scans, and these are basically cross-sectional views, and this says 25, we now take basically 50 scans, and we're able to look at each individual scan, so we're able to look at the whole macula, okay, and look at different areas of the macula and identify whether there's any leakage or abnormal vessels. Again, new standard for monitoring AMD. This is an example of the abnormal blood vessels growing underneath the retina. You can see here it's elevated, and you can see these pockets of fluid where the fluid is leaking, okay? And then this is really, again, that previous just show you the development of the resolution. This is an early stage OCT image, and this is really the state of the art today, and you can see the difference in the resolution. You're literally seeing the separate layers of the retina here, and you can identify each one. But again, these are the drusen, and so what we'll do is I'll look at somebody like this, and I'll say, okay, this is somebody who's ever high risk. This is somebody we need to monitor carefully. This is geographic atrophy. I already showed you this before. And again, the CNVM like I just described. So let's get a historical perspective on what's been going on over the last 30 years. 1980 was before my time, but unfortunately not too much before my time. But basically before 1980, there was no treatment for macular degeneration, none. And so if you were unlucky, you either developed geographic atrophy or you developed a disciform scar. but there was absolutely no treatment. The good news was the vast majority of people really had some visual loss, but did not develop either of those more devastating end-stage results. In 1983, thermal laser became available for wet AMD, and the thought was, okay, we have these abnormal blood vessels. If we laser those and obliterate them, we'll stop the process. Sounds great. 1993, we went into submacular surgery, and I'm going to review all these very quickly. 1998, cold laser for wet AMD, which is a little better. Each step made things a little bit better. And then in 2005 is really when things changed dramatically, and the miracles began to happen, quite frankly. Thermal laser photocoagulation, basically what we're doing is shooting a laser, identifying where the leakage was, and we were treating what we call the juxtafoveal vessels, meaning they weren't in the central vision area, they were next to it. And the idea was we would laser those and preserve the central vision. And the idea was to reduce severe vision loss. Unfortunately, the amount of people who had a classic, meaning well-defined vessels, which were juxtafoveal, next to but not in the foveal center, okay, was very, very small. The vast majority of people, and we'll show you in a few minutes, were not in that group. So it was a small subgroup of patients. They had to be well-defined lesions so we could identify them, and we could treat those with some success. The problem was 80% of these had a recurrence within 5 years, and almost all those recurrences were underneath the fine vision area. So we had some wins, but still the vast majority of patients lost their central vision over time. And again, these are examples of that. Here's the abnormal blood vessels here next to the fine vision area, next to the foveal center. Here's the foveal center. Here's an area of abnormal vessels. And these are two areas where we definitely would have treated with the laser. And how did the laser work? Again, these photographs are pretty demonstrative. Basically, you have the leaking vessels, and you would shine a laser in. And this is kind of an example of that clinically. Here's the abnormal vessels, early phase, late phase. A picture right after the laser, you'd see this whitening here, where basically with a heat reaction, we basically destroyed the leaking vessels, but we also destroyed the overlying retinal tissues. But again, this was viable because the central vision area was right there. And this is kind of the scotoma people would be left with. These are another clinical examples of the pre-treatment, and then what it looked like a month after laser treatment. You saw this area of what's basically atrophy, but no active leakage, and the central vision area was preserved. Again, different examples of it. Pre-treatment, post-treatment. This is what it looked like on a clinical exam. You see the vessels with some blood around it, and you see this large atrophic lesion, but the central vision area is preserved. Again, it sounded great, but the recurrence rate was 80% over 5 years, usually subfoveal, so most of these people, we were just buying them some time. Okay. The other problem with it is the vast majority of people had what was called occult neovascularization, meaning there was no well-defined area, so there was no area to treat. And this was probably 90% of people with wet degeneration had the occult. So it was untreatable. 50% of them would convert to the classic lesion. So what I would do is I would follow these people over time, watch their vision slowly deteriorate, and then they possibly would develop the abnormal vessels, and I would say, aha, and we would go and treat those, and again, maybe buy them more time. But it was inevitable that they were going to lose their central vision. And this is an example you can imagine. We know something's leaking here, but we really can't identify it very well, and it's underneath the fine vision area, so we're not going to treat it. This is another example of this occult, and again, this was the vast majority of patients. This is another occult lesion. And then there were the people who start off with the occult and then develop the classic. And sometimes we would try to treat those, but you can see here there's this what looks like a hot spot here, but then there's these two areas that are vaguely lighting up here. And so this was a patient who was not treatable, even though because there was really only one area that was well defined. So basically at the 1990, just when I'm finishing my fellowship, the vast majority of patients were not treatable. And we just held their hands, and like I said before, I felt like I was the Grim Reaper. Subfoveal laser came into vogue in 1991, and basically what the premise was is, okay, if we don't treat these patients with the lesions right underneath the foveal center, they're going to develop these large disciform scars and be left with this large scotoma. So let's do a study and treat those vessels underneath the retina and limit the size of the scar. And is there a benefit to that? So they did this huge study over several years. And basically the results were there seems to be at least some benefit to treating the vessels underneath the retina. It was a real leap of faith for a lot of the retina docs, especially the older ones, who had this whole thought process in their mind: we're preserving the fovea, we're preserving the fovea, we're preserving the fovea with laser, and all of a sudden, no, go ahead, laser through the fovea, you're still doing them some good. So that's kind of where we were at then. Again, the whole idea being, here's a lesion right in the foveal center. If we let that go, we know it develops into a disciform scar. We treat it early, okay, and we leave them with a scar underneath the fine vision area, okay, but again, we're limiting the central scotoma that they have. That was a treatment success in 1991. And again, here's a good example. Here's a disciform scar, no treatment. Here's somebody who had a treatment underneath the fovea. And you can see there is a subtle difference. There's more healthy sort of paramacular tissue around, and maybe their visual, their contrast sensitivity, things of that nature, more subtle vision testing was shown to be more, it was beneficial, but still not a win by any means. Not allowing them to drive, not allowing them to read. And again, we were trying to prevent this scenario here with that laser. And again, even with the treatment, you were left with this central scotoma. You were just limiting the size of it. So we were so desperate at this point that there was a movement for about 4 or 5 years of saying, okay, we can't do the laser underneath the fine vision area because we're going to destroy the healthy tissue. Let's go in and grab those vessels and remove them. And there was a small subgroup of people where you could identify this sort of plaque of vessels that was underneath the retina but not underneath the retinal pigment epithelium, and you could go in with forceps, make a hole in the macula, and grab those and remove them. Problem with that was the recurrence rate. Again, even in these patients, the recurrence rate was much like the laser recurrence rate of 80%, and the recurrences were typically underneath the fine vision area, and so an initial win ended up being a loss at the end of the day. So some novel treatments were tried. There was a guy in Florida who made a lot of money with people who were terribly desperate, saying, I'm going to do plasmapheresis on you. And plasmapheresis is kind of like dialysis. Basically, they take your blood, they clean it up, and they put it back in. And by removing the toxins, the thought was that's going to get rid of your macular degeneration. And he had people flying in from all over the country. I had patients where I was from in Buffalo saying, what do you think of this plasmapheresis? And I wasn't too excited about it. So you can imagine the desperation that people had. That's where we were. That they were desperate for anything. People were doing external beam radiation, much like with the radiation they do for cancer, for tumors. Okay, again, not really effective. Photodynamic therapy was a step forward where what we did was we said, okay, well, we want to selectively destroy the choroidal vascular membranes and preserve the foveal photoreceptors, limit the scotoma. So we would inject this dye that would bind to the abnormal blood vessels, and then we would shoot this cold laser, not a thermal laser, a cold laser, and it would excite the dye, destroy the vessels, but preserve the tissue. Again, sounds fantastic. Definitely was a step forward. The problem with it was that it was limited to these classic well-defined vessels. Again, they're the subgroup. They're maybe 10% of all people with wet degeneration. So it was, again, a limited subgroup. And this is kind of what it looked like. You'd have these vessels here. We would do the cold laser. And then afterwards, the vessels wouldn't be destroyed, but they would be inactive. And again, the problem with this was, and here's some clinical photographs. So you can see the lesion before treatment, then after. Really quite impressive. You can see that there's no leakage there, and we're not destroying the photoreceptors. And again, same thing here, okay? But here you're seeing pre-treatment, 1 week post-op, 2 months post-op, but then 3 months post-op, it all comes back again. And that's basically one of the problems with it, was that it almost always reoccurred. So you were getting multiple treatments, 4 to 5 a year, high recurrence rate. Definitely maintenance therapy was required, and each vial of this dye was $1,300. So it was an expensive therapy. It got a little better when we started injecting some steroid into the eye right after we did the laser. Okay, it did reduce the frequency of treatments. I can remember at the time, and again, I went through all these phases here. I thought PDT plus Kenalog was a wonder treatment. I thought this was fantastic, and I was, there was definitely more people that I was helping versus kind of being discouraged by what we were able to do for people. But really, the reality of photodynamic therapy was, at the end of the day, we were still just slowing the visual loss. Okay, we weren't maintaining vision over time. So in 2005, the Anti-VEGF Revolution occurred. And this drug called Macugen, which we no longer use and really wasn't all that effective, was FDA approved. And at the same time, this drug Lucentis, which you probably have heard about, was in phase 3 clinical trials, which were just being completed. And then there was this Avastin off-label use that began. So the premise of this whole thing was we came to realize that one of the things that was causing was the stimulus of these vessels growing was when the tissues were dying, the photoreceptors were dying, the retinal pigment epithelium was breaking down, is there was a release by these tissues of what's called vascular endothelial growth factor, VEGF. And the idea behind that was it was the cell's way of trying to regenerate themselves. Okay, and so the problem with that is, and this is the same thing that happens with diabetic retinopathy. When the tissues die in diabetic retinopathy, the patients have a large elevation of their vascular endothelial growth factor, which promotes new blood vessel growth. Well, that's exactly what is happening here. We're getting new blood vessel growth underneath the macula and causing all the problems that we just talked about. So the idea was, if we can suppress this VEGF, okay, we can maybe suppress these abnormal blood vessels. So there were two drugs at the time. I talked about Macugen. Macugen really, I used it a couple of times, was underwhelmed. I can remember I used it on one patient specifically. It didn't work. Their vessels grew more, and I ended up doing photodynamic therapy on them and stopping things. And that's when I lost my enthusiasm for Macugen. But there were two drugs, Lucentis and Avastin. And again, the idea behind these drugs is that they're a potent binder of VEGF and inhibit this VEGF and basically block it and shut it down and suppress it. They're almost identical chemical structures. Avastin, interestingly enough, was approved for colon cancer in 2004. The idea behind this was, how do we kill the tumor? Well, we kill the tumor by killing the blood supply. So the idea was to inject Avastin, okay, systemically by an IV, very high doses, and by doing that, kill the new blood vessel growth within these tumors, and therefore the tumors were shrinking. And again, it was palliative. It really wasn't all that effective, but it was FDA approved, which proved to be really fortuitous for us. Lucentis is basically the sister drug of Avastin. They're both made by Genentech, the same company. There's a little chemical structural difference between the two, but they're essentially identical. The Lucentis trials were being completed, and actually were completed in August 2005. They presented the trial results, and the trial results were just absolutely astounding. 95% of the patients maintained their vision. 40% of them improved to 20/40 or better, which is driving vision. But Lucentis was 2 to 3 years away from being FDA approved. The FDA doesn't move quickly, okay? So these are just some pictures of patients that were treated with Lucentis in the trial. So you can see this just nasty looking lesion here. With the OCT. This is pre-treatment, and this is one injection later, 2 injections later. Basically, all of the blood is gone. The OCT looks essentially normal, and their vision returns to a remarkable level. So you can imagine somebody like me seeing this and just being absolutely blown away because, knowing the end stage of this disease for the vast majority of people prior to this, it was astounding. And again, this is another pre-injection photograph. 1 month, this is just 1 month later, all this fluid is resolved. You can see the shrinkage of the abnormal blood vessels, and all the fluid is almost there. And again, the photoreceptors really were not damaged at all and are functioning again. So there's this guy in Florida who's a retina specialist. I hesitate to use the word that he's I would say a colleague of mine, but I would not say we're in the same stratosphere. This is a guy who is at Bascom Palmer, one of the world-renowned areas for retina and ophthalmology in general. And he was saying to himself, just thinking one day, he knew Avastin and Lucentis were very similar drugs. He knew we couldn't get Lucentis for 2 to 3 years. So now, while we know this Lucentis drug is working great, we're still doing this photodynamic therapy because it's the best thing we have, okay, and we have nothing else. And he says to himself, well, Avastin's FDA approved. Once a drug is FDA approved, physicians have the ability to utilize it any way they deem reasonable, okay? And so what he did initially was he treated patients with, who were failing PDT, who had nothing to lose, and he said, we're going to give you the systemic treatment of Avastin that they give for colon cancer, okay? It was effective, but it was costly. and there were tremendous side effects, high blood pressure, heart attacks, strokes. It was not a good drug in high doses. But it worked. So then he said to himself, well, people are, these are elderly people in general who are not all that healthy. We give them this drug, the treatment could kill them, let alone, anything else. So he said, well, why not just inject it right into the eye? We inject steroids, and at that point we were injecting steroids into the eye. And he said, is there any toxicity to it? So he did some animal studies, figured out that there probably wasn't any toxicity to the Avastin. And so basically he would take a vial of Avastin that they would use for one treatment of IV Avastin therapy, okay? And he just drew off very simply into a syringe, okay, 0.1 cc, which is 1.2 milligrams. And he injected it into the eye as his next sort of treatment trial. And again, he was dealing with people who were desperate, had nothing to lose. And he did a small study just on his own patients, found that, the patients tolerated it well. The cost was ridiculous because you're buying this big vial and you can get 400 injections out of one vial. So it ends up being $50 an injection. If you remember, photodynamic therapy was $1,300 a shot. This is $50 and works, 100 times better. So he presented his study at one of our big meetings, and basically, because people were so desperate, and also the cost was so low, physicians were like, okay, the drug's $50. Most patients can afford $50. All right, we know it probably works. So there was this groundswell of use of Avastin. In the meantime, Lucentis is going through the FDA approval process, but it's not there. Well, it didn't take less than 6 months before basically, by 2006, Avastin became the standard of care for treatment of wet macular degeneration, to the point that Medicare did something they never do. They began reimbursing for Avastin off-label. Medicare just doesn't do that. They don't pay for off-label use of a drug. But they were so blown away by the effectiveness of it and the relatively low cost. Relative to a lot of things they pay, they're looking at $50 a shot. They're like, we're going to pay for this. It's going to save us money at the end of the day, especially when they're looking at photodynamic therapy and all the other expensive ones. So they did something that was unprecedented for them, and they started paying for it. So then there was this 5-year period where Lucentis gets approved, and Genentech owns both drugs. They're not happy. Their shareholders are not happy because their wonder drug that they want to charge $2,000 a shot for has already been replaced by Avastin, which they own too, at $50 a shot. So to make a long story short, things got very ugly. Genentech tried to block us using it legally. It's not FDA approved. They did this whole PR thing. I had patients of mine being called by Genentech saying, he's using Avastin on you. It's not FDA approved. I mean, it's just a nightmare. So finally, a national study was done, the CATT study, C-A-T-T, which looked at Avastin versus Lucentis, saying, okay, let's find out if one's more effective than the other. We know the whole FDA approval, thing and off-label use, but let's see if one's more effective than the other. And basically, they're equally efficacious, number one, and number two, the side effects, which are absolutely minimal, okay, are equal between the two of them. So that ended the debate. So we went basically for 5 years. We used Lucentis and we used Avastin, and it depended on the retina surgeon whether they used one or the other. And what was interesting was sometimes I always started with Avastin, but there were people who failed Avastin, or they initially did well with Avastin and then failed. And so we would switch to Lucentis, and a small group of them would then respond. So there definitely was a difference between the drug. My thought always was 80% of people would respond to both drugs. There's 20% who would respond to one or the other. Yes?
How many Avastin shots would you need? Just one?
We're going to talk about that in just a few minutes.
Thank you.
So now we're at 2016, and things have changed a little bit since 2011, but not a whole heck of a lot. If you went to your ophthalmologist or optometrist and they said, gee, I think you might have macular degeneration, I want you to go see the retina doctor, this is what you would go through at this point. You'd get a dilated fundus exam, we would do OCT imaging, and maybe we would do fluorescein angiography. Maybe. If I was suspicious for leaking vessels, choroidal neovascularization, I would do a fluorescein. Again, the vast majority of people don't have the wet degeneration. So most of the time, people just get an OCT, and then based on that, sometimes if I find that there's wet degeneration, I will go ahead and get a fluorescein. So, a fluorescein is that test where we inject the dye into the back of the hand, and it lights up the abnormal vessels. We talked about, you'll see some. Yes, I'll review it with you in a few minutes. So with dry degeneration, we would, a lot of people come in looking like this. They'll be sent in. We'll do an OCT. We'll see these irregularities here and here. Here's dry degeneration with the drusen. Some people come in and they already have atrophy, and there's really not a heck of a lot we can do for that. But in essence, again, the vast majority of people, 2016, they have drusen, they have some retinal atrophy. We will put them on a vitamin therapy, which I'll talk about in a few minutes. And most importantly, we will get them to start using an Amsler Grid on a daily basis, and I'm going to talk about that. And I may see them, depending on the severity of their disease, once or twice a year going forward. With dry degeneration, if there's no evidence of the abnormal blood vessels growing, the things that we talk about with our patients right now is the vitamin therapy, the ARIDS, and also the Amsler Grid monitoring. Those are the two key things that I want people to walk away with after I've seen them for their initial visit. This is an Amsler Grid, and the beauty of the Amsler Grid is it allows us early detection of these abnormal blood vessels when they do grow. So anybody who comes into my office with any sort of high-risk characteristics for wet macular degeneration, I will give them an Amsler Grid, and I will show them this picture, and I tell them if they start to see this, they're to call me, and I will get them in within a day or two. And the idea behind that is if we catch things early with the abnormal blood vessels, these drugs are absolutely amazing. Okay, when the blood vessels are more mature, they do respond to treatment, but they're not as effective and people require maintenance therapy. So this is just absolutely the most important thing I'll do for people. A lot of times I'll come in with wet degeneration in one eye and the vision's not going to be that great. I know it's not going to be great. And I'll tell them, I said, we're going to treat your right eye. I said, but the most important thing I'm going to do for you today is to get you to use this Amsler Grid to monitor your other eye. Okay, because if it happens in your other eye, and you are monitoring the grid, I guarantee you'll be okay. I mean, guarantee is a pretty strong word. But as long as I use the grid, and I tell them in a perfect world, you use it every day, okay? So the vitamin supplementation, there was a study done, the ARID study. Basically, the idea behind the ARID study and what it found was that people with high-risk characteristics for macular degeneration, a lot of those drusen, there's a benefit to being on this ARIDS vitamin therapy. It slows down the progression of the drusen. It decreases the development of abnormal blood vessels, the wet degeneration. There's about a 20% drop in the rate of wet degeneration developing in those patients who are on the ARIDS vitamins. So there's a definite value to it. This is the ARIDS formula. Don't try to write it down. You can Google it. You can go on my website. It's all over the place. And you can go to the drugstore and say, I need the ARIDS 2 formula for macular degeneration. There's a ton of companies producing it. The pharmacist will help you. So what's the future treatment of dry age-related macular degeneration? Well, right now, the whole goal is we want to try to slow the progression of the drusen forming and getting worse. But most importantly, it's this atrophy. That usually with dry degeneration, it's the people who develop the atrophy, okay, who we really don't have anything to help them with right now. And we're trying to figure out ways of slowing down the development of the atrophy. And I think we're 5 to 10 years away from coming up with something that's going to be effective. We're looking at oral agents. We're looking at topical eye drops. We're looking at injectable agents, okay, trying to find something that will work. And we will find something. There's no doubt about it, but it's going to take a while. But it's down the pipe. For sure. Now, the last thing is, for those patients who've already lost their vision, okay, they already have the atrophy, the foveal photoreceptors are gone, they're not working, we're going to have something that's pretty incredible in the next 5 to 10 years again. We're going to go in and do what's called a vitrectomy, and we're going to elevate the macula area. We're going to create a little bleb of fluid underneath the macula, blow up the photoreceptors, and we're probably going to inject stem cells underneath the retina in the foveal center, and that's going to regenerate the RPE. Because that's really the problem here. It's an RPE disease. So if we can regenerate the RPE, we're hopeful that the photoreceptors will regenerate and people can regain vision. And I would say in 10 to 15 years, that's going to be a common procedure. And it's just going to be absolutely amazing, from where we've come from. Again, we're not there yet, but that's where it's heading. Wet degeneration, we're going to spend more time on because that's really something where the treatments are much more exciting at this point, okay? And again, this is just a picture on the floors. This is that fluorescein angiogram. We've injected dye into the patient's veins in their arm, and the dye goes up and it fills the blood vessels of the retina, but it also fills the abnormal blood vessels, which then leak fluid. And that's what a fluorescein is. These are just more pictures of the wet degeneration. This is a clinical picture. This is the fluorescein with it. The dark here is the blood blocking, okay? And again, you see it down here. And then this is what the OCT looks like. Pretty nasty stuff. So right now, 2016, in my office, if you come in looking like that, we're going to inject you with Avastin, okay? And so I want to talk briefly about, what's involved. It sounds horrific. Gosh, getting injected, into your eye with a drug. That's kind of what it looks like. It's an office procedure. We use a topical anesthetic. We numb the eye. After we discuss everything, I'll say, I want to inject Avastin into your eye today, and I'll start putting some drops in. I'll go do something else. I'll come back. I'll put some more drops in. I'll go do something else, and I'll put some more drops in. I'll wait 5 to 10 minutes for the drops to take effect. Then I put a lid speculum to pull back the eyelids because there's a lot of bacterial debris in our eyelids, and so we want to pull those back and avoid that. And then I'll put in some betadine disinfectant drops to kill any bacteria that's on the surface of the eye. And then we use a 30 gauge needle, which is so small that it's self-sealing, to actually go in and do the injection itself. So this may feel a little gruesome, but this is kind of what it looks like when we do it. Okay, you can see the needle there. This yellow that you see is actually the betadine disinfectant. We've pulled back the eyelids with the lid speculum because there's too much bacteria there. And people obviously will squeeze their eyes too. So we're trying to prevent that, okay? But you can see it's a pretty small needle, and again, it's a self-sealing wound. So post-injection, most people will have some dry eye type of irritation. And usually this is not the result of the injection itself, it's a result of the betadine. And the betadine works wonders in killing any bacteria. Okay, but it's really toxic to the conjunctiva. So one of the things I spend a lot of time is irrigating the eye after the injection and getting rid of the betadine. But regardless of that, some people, especially in this climate like this, a dry climate like this, dry eye is more prevalent here. And I actually had to adjust my treatment methodology when I came from back east where it was humid, coming out here because people were just miserable the first couple months I was here giving these injections. And really what it came down to was I was using more betadine, and I had to back off on the amount of betadine I used, and I did more irrigation. I had to adjust things. So it's a real entity. There's definitely a little irritation. There's a scratchy sensation. But in 9 out of 10 patients, even if they have a little bit of discomfort, if you lubricate your eye with artificial tears or those artificial gels that they have, it's really very manageable. One of the other things that happens probably 50% of the time is people will have what's called a subconjunctival hemorrhage afterwards. There's very small blood vessels in the conjunctiva. We really can't see them, and when we inject in, sometimes we'll rupture one, and it's one of those things that looks bad, but it usually goes away within about a week. There is one, although horrible complication from these injections. This is the only bad, I tell people, the drug itself really has no toxicity. We're using such a small dose. It has no retinal toxicity. It has no systemic toxicity. But the one bad thing that can happen is infection, okay? And it's about a 1 out of 1,000 occurrence rate. I personally haven't had one in about 5 to 6 years, probably 6 years now. And I hope to never have another one. It's why I use the betadine. Some people say that betadine's killing me, and I'm like, yeah, I know, but you're getting it. It's not optional. I won't inject you unless I use betadine. I just won't. You'll have to find another retina doctor. And so what happens is you get this intraocular infection, which can happen usually 1 to 7 days post-injection. There's pain, decreased vision, and what we have to do is we have to inject intravitreal antibiotics to kill the infection. All right. Now, vast majority of the time, the antibiotics work and people do okay. I just had a gentleman from Wyoming whose retina doc was flying in from Salt Lake, giving his injections and flying back. He developed an infection. There was no one who could see him. They finally got a hold of me, and I said, sure, come on down, but it was 2 days later. And he's now having his eye removed. So it's a real entity, and it's one of those things that I just hope I never have to deal with again. Most of the time, though, if we catch it within the first 24 hours, people do well. the vast majority. But there is a nightmare scenario like I just told you, so you have to have a healthy respect for it. And it wasn't the first eye I've seen that's been lost because of this, so it's a real deal. So anti-VEGF 2016, the drugs are effective. There's very little risk other than what we just talked about. But we have 3 different medications. So which one do you use? You're going to go in, and if you do some research, you're going to say to your retina doctor, well, why are you using this one, why are you using this one, or why aren't you using this one? One of the things that I take into account, because I think as physicians we have a fiscal responsibility to utilize medications that are proven to be efficacious and don't cost Medicare an arm and a leg. So everybody, and my mother's now passed away, but I used to tell people, if you were my mom, I'd give you Avastin. Okay. If it was me, I'd say, give me Avastin. All right. And Lucentis and Eylea, which we'll talk about in a minute, they're all probably, we know Avastin and Lucentis are equally effective. That's been clinically, scientifically proven. Eylea, they really haven't studied them head to head. There's a suggestion that Eylea may be better in some people, but still 80% of my patients respond to Avastin. So my thought process is you get Avastin first, and if it doesn't work, or you get worse after the first one, I mean, if there's, my tolerance for switching is low, okay, but I still like to use Avastin first. And I'm happy to use the other ones if Avastin is not doing its thing. Eylea, okay, probably is a better drug because it binds to more VEGF receptors. It also binds to placental growth factor. It has multiple ways of interacting with VEGF. And it's also a different drug, and that's why I think it's probably a better drug, but it's still $2,000 versus $50,000. And again, most people do well with Avastin. Okay, that's pretty much. And also the company that owns Eylea, okay, will tell you that there's a longer treatment interval. Yes and no would be my answer to that based on my experience. So again, in anti-VEGF therapy for 2016, on your initial treatment, you get Avastin, you get 3 monthly injections. If you come back after the first month and you're not any better or you're worse, you just get one Avastin, then I switch you to Eylea. So it's, again, I will switch you pretty quickly if I'm not seeing the response. I call it the salvage therapy with Eylea. But in all these patients, except for the rare exception, and I'll discuss that in a minute, you're talking about maintenance therapy. 90% of patients who come to see me and have these injections initially, they're with me theoretically forever, okay? We can't cure this yet, okay, but we can control it. So what does that mean? So what it means is maintenance therapy. It means long-term monitoring and treatment. If we get a great response with the anti-VEGF medication, your visions come back, you're going to be using that Amsler Grid in the treated eye and the untreated eye. And you're going to call me if you notice any change. And what we're trying to do, and what I tell people my job is to maintain the best vision possible for you with the least number of treatments. Anybody can do the injections. The art is determining which drug to use, when to use it, and trying to get the number of treatments, to minimize them to a level that is tolerable for people, and to maximize the vision at the same time. Okay. Your follow-up office visit. So we do our 3 injections. You look great. The eye, the leakage is gone. There's no leakage there at all. We're going to follow you month to month for a while, and then we're going to try to extend your time period to 2 months and potentially 3 months. Usually with most people, I won't go longer than 3 months in between treatments because these drugs just tend not to work after 3 months. So if you've shown that you're going to have a recurrence, if you come in, let me take a step back. If you come in, you have your 3 injections, everything looks great, I won't give you another treatment. I will follow you month to month for 6 or 7 months to see if you have a recurrence. Some people don't have a recurrence, so they don't need treatment. That's the rare exception. What is that rare exception? Well, it's typically the patient with a very, very small lesion that was caught very, very early. And I use the analogy of a weed in your garden. If you think about a weed in your garden and it's small and you see it very early on, you take some weed killer, you spray it, it dies, it doesn't come back. You get a big, healthy weed that's been there for a while. You can spray it and it dies, but then it comes back. And I think it's a level of maturity of the vessels. If the vessels are still immature, the VEGF works, it suppresses them and sometimes eliminates them. But if those vessels are mature, the medications will suppress them, control them, but off the medication, it's coming back. So again, very important in the other eye, if you're only being treated in one eye, to monitor that grid so that we get there early and minimize vision loss and minimize the amount of treatment that you need. So, still, it's all a positive, but gee, who the hell wants to get an injection every month or every 2 months or even every 3 months, okay? No one does, I mean, they're appreciative of the treatment, but they still don't like the treatment. So when you come for your follow-up office visits, you'll still get a dilated exam, you'll get the OCT imaging, we won't be doing fluorescein, and then we make a decision on treatment based on where you're at. That's now. What's the future? The future, okay, is combination drug therapy. That's what's being looked at now, and seeing if that'll be more effective. Again, lowering the number of treatments, decreasing the treatment burden that people have, okay? Trying to get longer-acting drug therapy, okay? And that corresponds with better drug delivery. So the reality of the economics of medicine right now is this diagram I'm showing you is a vitreal implant that releases some antiviral medication, okay, for an HIV type of virus. And we put this in, it's called a Retisert. And I've been putting those in for 15 years. The technology to put the drugs that we're using now and we're injecting, to put them into a small, slow-release mechanism in the eye so that you maybe get one every 6 months, maybe it's every year, maybe it's every 2 years, has been there for 10 years. However, there's no financial incentive for a company like Genentech to give up their medication and put it in this device. Their shareholders would not be happy with them. And that's basically what's been slowing it down. The thing that is interesting, the thing that has moved the needle, so to speak, especially with Lucentis, is Eylea is probably a better drug than Lucentis. It costs the same, so most retina docs are using Eylea as their second-line agent, and Lucentis has lost market share. Now Genentech is saying, okay, we've lost market share, now we're willing to put Lucentis in one of these long-acting delivery devices. That's the economics of medicine, and that's what's driving it. And it is what it is. There's nothing we can do about it. But the reality is, within the next 4 to 5 years, it's not worth talking about the different ones that are out there because nobody knows which one's going to be the one. But the reality is we are going to have a long-acting drug delivery device that we're somehow going to implant, probably not in the office, probably a minor procedure, as an outpatient in an ambulatory surgery center or in a hospital setting that takes 10 to 15 minutes, and you're going to have it put in. And the question is, which drug are they going to use? Okay, and it may be a drug that we don't even have yet. All right, is it going to be multiple drugs, and how long is it going to last? We don't have the answers for that yet, but it's only going to get better than it is right now. It's and will it be a cure? I would make the argument that if we get a slow release of drug and maintain a level of concentration in the eye for a period of a year or 2 years, you may see that that these vessels just don't come back. Right now, basically, we inject, they have a high level of drug in the eye, and then slowly over a month or 2 months or 3 months, that drug level goes down and the vessels come back. But if you're maintaining a level of drug concentration in the eye for a definitive period of time, 6 months, a year, I'm thinking that maybe when it runs out, the suppression will have been so effective at a high level that these vessels won't come back. So it may be curative, okay? But the take-home message would be we have great treatments now. The burden is still not where we want it to be. It's a little bit more than anybody would prefer, but the alternative to that is blindness, which nobody wants. So I would say the vast, vast majority of my patients are pretty appreciative of what we're able to do now. The good news is that it's only going to get better, over time. And that's it. Questions?